Good morning. Thank you so much for allowing me to share the NIH data cohort information with you. My name is Carol Barron and I'm ready to go. So way back in 2014, we first described our experience with DATA2 in the New England Journal. And at that time, our cohort of patients were pretty similar. They were in an inflammatory vascular setting, and they presented with ischemic strokes, fevers, libido, and some of them had polyarteritis nodosa. But within a short period of time, we started seeing patients with other complaints or other problems, such as immune dysregulation and hematologic abnormalities. And it didn't really fit into our initial idea of what the cohort looked like. So over the years, we have described the expanding phenotype of DATA2 into three main overlapping categories. One is the inflammatory vascular, including ischemic strokes, fevers, libido, polyarteritis nodosa, Raynaud's, and a vasculitis or vasculopathy. A group of syndromes that fall under the immune dysregulation, including hypogammaglobulinemia, transitional B cell deficiency, memory T cell deficiency, and NK cell deficiency, and then a group of patients with hematologic abnormalities ranging from pure red cell aplasia, cytopenias, and bone marrow failure. So I'd like to present the clinical follow-up of our 58 patients that have been evaluated at the NIH. All underwent extensive clinical, laboratory, and imaging evaluation. But I want to add that there have been two other patients that were not included in this series. One patient seen 5 years after marrow transplantation for presumed GATA2 deficiency was later found to have DATA2. And another patient presumed to have ALPS with a history of fevers, hepatosplenomegaly, lymphadenopathy, and immune cytopenias was found posthumously to have DATA2. So of our 58 patients, 33 were females. There were 8 sibling pairs, and there were 2 families with 3 affected individuals. All patients had diallelic loss of functional mutations in ADA2, leading to decreased protein expression and function of adenosine deaminase 2. So I'm going to go over some of the clinical features of our patients. Most of our patients had a history of fever, was about 90%. And as opposed to our initial group of patients who all had strokes, only about 45% of our patients had strokes. There are lesser amounts that had diffuse lymphadenopathy, systemic hypertension, and portal hypertension. So of our 58 patients, 26 or 45% had strokes. And most of these were ischemic strokes, 73%. 23% had both ischemic and hemorrhagic strokes. It was thought that these patients with the hemorrhagic strokes, this was due to treatment with either antiplatelets or anticoagulation. However, one patient appeared with just a very large hemorrhagic stroke that had not been on any of these treatments and had not had a previous ischemic stroke. So we still think that the treatments with antiplatelet agents and anticoagulation should be questioned in these patients. It certainly is possible to have a hemorrhagic stroke without these medications. The average number of strokes in our patients was 3, and it ranged anywhere from 1 to 11 strokes. The average age at the first stroke was 6.5 years with a range of 0.4 years to 20 years. And very interestingly, 10 patients had moderate to severe deficiency on neuropsychiatric testing. Now, it's possible that this is an underestimate since not all of our patients underwent neuropsychiatric testing. We've described portal hypertension. This occurred in 7 of our patients. The liver histology in these patients revealed hepatoportal sclerosis, portal hepatitis, and portal vasculopathy. And nodular regenerative hyperplasia was also seen. And interestingly, one patient required a splenorenal shunt following a massive varicocele bleed. We also saw significant peripheral vasculopathy, and 5 of our patients on MRA had signs of peripheral vasculopathy, and 1 actually required amputation of gangrenous digits. We have 3 other patients awaiting evaluation. Abdominal MRA was abnormal in 8 of 14 patients that were evaluated, revealing arteritis, aneurysms, and/or renal infarcts. 5 of our patients actually developed bowel necrosis, and 3 patients had myositis on MRI. Of our 58 patients, 66% had low immunoglobulins. Of these, 55% had low IgG, 62% had low IgM, and 43% had low IgA. Also, about a quarter of our patients required immunoglobulin replacement. When we tested antibodies following vaccination, we found that 41% had inadequate antibody response. All this supporting the fact that the immune system is indeed affected in patients with DADA2. As far as lymphocyte phenotyping, you'll notice that of our patients, only about 35% had a normal lymphocyte phenotyping. What was really striking is this low or absent class switch memory B cells, and this was up to about 75% of our patients. Low memory T cells was found in about 55%, and low NK cells was found in about 45%. An abnormal CBC was found in almost half of our patients, and the abnormalities ranged anywhere from pancytopenia, severe anemia, immune-mediated neutropenia, lymphopenia, and thrombocytopenia. You can also see that there was an inflammatory burden seen in our patients, with a large percentage of our patients having elevated SED-rate and C-reactive protein. As far as treatment of our patients, we've already published the preliminary evidence that TNF blockade prevents future stroke, so we have put our patients on anti-TNF agents. We've also shown that it decreases the inflammatory burden, such as the SED-rate and CRP. And we've also seen there's an improvement in hepatic manifestations of disease, both vascular and parenchymal. The FibroScan improved in 10 of 13 of our patients. However, 3 patients developed evidence of liver fibrosis while on treatment, and an additional patient, liver failure progressed with portal hypertension. We've also shown that TNF treatment has an effect on the TNF that is found in the blood vessel walls. Here are 2 control patients, and here are 4 patients before treatment and after treatment. These are skin biopsies, and the red shows the TNF, and you can see TNF in the blood vessel and the endothelium. And after treatment, it improves, and also the endothelial layers are now more normalized. Skin manifestations improved in some. However, there was little improvement in the peripheral vascular disease. As far as hematologic response, the patients with pure red cell aplasia remain transfusion dependent, and patients with the trilineage bone marrow failure, trilineage bone marrow failure actually developed in 1 patient on a TNF inhibitor. The effect on low serum immunoglobulin levels, some patients demonstrated a resolution of their hypogammaglobulinemia. However, most continued to demonstrate low levels of immunoglobulin. And interestingly, 8 patients were noted to develop hypogammaglobulinemia while on treatment. 5 of our patients receiving anti-TNF treatment required hematopoietic cell transplantation. There have been no serious adverse events associated with anti-TNF therapy. However, I'd like to point out that 1 patient actually developed biopsy findings compatible with IBD. This is a little unusual because some TNF agents are actually used to treat IBD. So this is a summary of our hematopoietic cell transplantation in 6 patients. Patient number 1 was the one that I had mentioned earlier that was transplanted for an indication of GADA2 and was later found to have DADA2. There are 3 patients that required more than 1 transplantations, number 2, number 4, and number 5. And this was for graft failure. Number 2 and 4 required 2 transplantations. Number 5 actually needed 3 transplantations. You can see the list of complications is ranges from GVD to the severe systemic inflammatory response and sepsis. And I'll summarize the other findings in this next slide. So all of our patients had been on anti-TNF agents prior to transplant, with the exception of the patient that was presumed to have GATA2 deficiency. Myeloablative conditioning was used in 1 patient. However, the others received various degrees of reduced intensity or non-myeloablative conditioning. 3 patients had secondary graft failure necessitating subsequent transplants, with 2 requiring 2 transplants and 1 requiring a third. It's of note that these 3 patients required very prolonged hospitalizations ranging from 77 to more than 390 days. And all 3 of these patients had immune-mediated neutropenia as one of their indications. All patients are still alive and have discontinued their anti-TNF therapy. And as I've shown, there have been significant complications that we observed. And our feeling is that we really have to do better. We have to come up with better ways of conditioning the patients and following these patients. And we probably need to do that as a collective group across the different countries seeing patients. So Chip asked me to comment on what's interesting or new in the NIH data cohort. I think it's interesting that 10 of our patients, as I mentioned, had moderate to severe deficiency on neuropsychiatric testing, and this probably is an underestimate. We have seen a significant amount of non-CNS vascular disease, including peripheral vascular disease, including amputation of digits in 1 patient, significant portal hypertension, and myositis in several patients. I've described the spectrum of disorders of the immune system with abnormalities in immunoglobulin and response to vaccines. I've also talked about the effect of anti-TNF therapy and the results of hematopoietic cell transplantation in 6 patients. So this kind of summarizes our view of the expanding phenotype of DATA2. The spectrum of DATA2 continues to expand to include ischemic and hemorrhagic strokes, hematologic abnormalities, vascular pathology, portal hypertension, immune deficiency, and bone marrow failure. As the phenotypic presentation is likely to continue to expand, it's important to investigate any new complaints. In addition, it's important to monitor patients closely as their phenotypic presentations can change with time. And most importantly, improvements in hematopoietic cell transplantation are certainly needed. Thank you very much.